Hello everyone. Thank you for giving me the opportunity to join this year's Transplantation Society of Taiwan annual meeting. My name is Ryoichi Imamura, Department of Urology, Nagasaki University Graduate School of Biomedical Sciences, Nagasaki, Japan. Today, I'd like to talk about the safety and efficacy of iberolims, a type of mTOR inhibitor. Today's title is mTOR inhibitor in kidney transplantation, a smart choice for long-term benefit. I'll be presenting the kidney transplantation practices in Japan with a special focus on de novo malignancies post-transplantation, as well as insight into the efficacy and potential adverse events associated with mTOR inhibitors like iberolims. I have no conflicts of interest related to the content of this presentation. Let me give a brief overview of today's agenda. First, I'll cover the general landscape of kidney transplantation in Japan, followed by discussion on the incidence and management of de novo malignancies that can arise in transplant recipients. We will then move into the clinical outcomes and considerations surrounding the use of iberolims for these patients, including a review of both benefits and adverse events. First, I'll talk about kidney transplantation in Japan. This slide shows the trend in renal transplant cases in Japan over the past decade. We can see a predominance of living donor transplants over deceased donor transplants, which is quite different from practices in Western countries. The reasons behind this are multifactorial, but regulatory, cultural, and demographic factors play a major role. This chart presents the key characteristics of kidney transplant recipient in Japan. Our transplant population is generally older with high rate of comorbidities. This influences our post-operative care, immunosuppressive protocols, and cancer screening practices. Considering about the gender of recipient, over 6% was male in both living and deceased kidney transplantation. Here, we can see survival rate of kidney transplant patient in Japan separated into living donor and deceased donor transplants. The patient survival rate of living and deceased kidney transplantation of 5 years and 10 years are 96.6% and 19.6% in living, 92.5% and 83.0% in deceased, respectively. While short-term graft survival rate is very good, long-term survival rate is not enough. I do believe in the future we can improve the result, but there are many problems to improve the long-term survival rate. Similarly, this slide shows graft survival rate for both living and deceased donor transplants. The graft survival rate of living and deceased kidney transplantation of 5 years and 10 years graft survival rate are 93.0% and 81.3% in living, 87.8% and 74.4% in deceased, respectively. While short-term graft survival rate is very good, but long-term survival rate is not enough too. How can long-term survival and graft survival rate be further improved. This slide categorizes causes of death among kidney transplant recipients in Japan. The most common causes include infections, de novo cancers, and cardiovascular diseases. Notably, de novo cancers are significant causes of mortality in long-term transplant recipients, which brings us to the importance of effective immunosuppression management that also considers cancer risk. In addition, infections are also critical concern, especially in the early post-transplant period. Next, I'll talk about de novo cancers after kidney transplantation. De novo cancers is a notable risk post-transplantation due to long-term immunosuppressive therapy. In 1994, Penn has reported about 6% of U.S. kidney transplant recipients suffered from de novo cancers. Standardized incidence rate SIR was 4.5. The incidence of de novo cancers among kidney transplant recipients globally ranges from 2.3% to as high as 31%, and about 10 to 15% of recipients develop solid tumors 15 years after renal transplantation. As this slide shows, SIRs for de novo cancers vary widely around the world. Research indicates that factors such as region, race, and diet can significantly impact the incidence of post-transplant cancer. For example, although the data is a little old, rates reported from US and Taiwan demonstrate considerable differences. While the SIR for kidney cancer and urothelial cancer is markedly high in Taiwan, the SIR for non-melanoma skin cancer is high in the United States. It's well known the SIR for skin cancer is significantly higher in Australia and New Zealand. These variations emphasize the need for country-specific cancer screening and prevention strategies. What about the data from South Korea, also in East Asia? A study tracking over 14,000 kidney transplant patients from 2002 to 2070 showed an increasing incidence of de novo cancer. The data suggests the older kidney transplant recipient and steroid were risk factors for de novo cancers. I'd like to indicate the cumulative cancer incidence in the right graph. It was about 10% at 10 years after kidney transplantation. In this slide, we can see SIRs for de novo cancer after kidney transplantation at Osaka University, where I belonged until 2022. According to our data, the SIR for kidney transplant recipient from 2001 to 2019 was 2.24. In other words, the cancer incidence rate in kidney transplant recipients in Japan was 2.24 times higher than that of the general Japanese population. The SIR for men was 1.94 and for women was 2.78. Similarly, the cancer types that showed high SIRs among kidney transplantation recipients from 2001 to 2019 were renal cancer and urothelial cancer. That SIR is 11.98, PTLD SIR is 8.91, and non-melanoma skin cancer SIR was 17.93. On the other hand, the SIR for liver cancer has dropped significantly since the 19th to 1.81, probably due to a decrease in blood transfusions and adverse advances in treatment for hepatitis viruses. Similarly, preoperative screening and eradication for Helicobacter pylori have resulted in low SIRs for gastrointestinal cancers. This chart illustrates cumulative cancer incidence and mortality for kidney transplant recipients at Osaka University. The data reveals a progressive increase in both incidence and mortality over time. The SIR is about 20% in 20 years after kidney transplantation. In 2001, immunosuppressive therapy changed significantly in Japan. MMF and bacilliximab became covered by public health insurance, and immunosuppressive therapy became more powerful. As a result, the cumulative cancer incidence curve is rising comparing to before 2000. The table on the left shows the type of cancer that have been diagnosed so far. The most common are PTLD, skin cancer, breast cancer, and renal cancer. But recently, there has been an increase in breast cancer and prostate cancer, possibly due to an increase in elderly recipients. The table on the right shows the risk factors for de novo cancer. Age, duration of dialysis, and blood transfusion history were considered risk factors. The duration of hemodialysis before kidney transplantation is very important. This research has shown a correlation between the duration of hemodialysis before transplantation and the incidence of de novo cancer. Longer hemodialysis duration often correlates with a higher risk of post-transplant malignancies. This finding suggests early transplantation could reduce cancer risks, emphasizing the importance of timely transplantation whenever feasible. On the other hand, age and dialysis duration were identified as risk factors for cancer-specific survival. Here, I present a comparison of patient and graft survival over different time periods according to the presence or absence of de novo cancer. Those who suffer from de novo cancer have a lower cancer-specific survival rate. However, it's very interesting to note patients with de novo cancer have a higher graft survival rate. It is speculated while patients suffer from de novo cancer due to excessive immunosuppression, the graft survival rate is higher because there is less rejection. I will show you the risk factors that affect survival rate for de novo cancer. Cancer screening provides substantial benefits for transplant recipients. This slide highlights the importance of routine screening as a part of post-transplant care. Early detection and intervention can significantly enhance survival. Furthermore, this report lists CNI as a risk factor, probably due to its concentration. As I will explain later, iberolimus can reduce the dose of CNI, so the benefit of mTOR inhibitor for de novo cancer is predicted. Now, moving on to the use of iberolimus, an mTOR inhibitor in kidney transplantation. This section will focus on the role of iberolimus as a potential agent for reducing de novo malignancy risk, improving graft survival, and supporting long-term patient outcomes. Generally, iberolimus is often used in place of MMF or CNI, But in Japan, facilities have implemented the addition of iberolims to the normal protocol for CNI and MMF. This is done to take advantage for each drug, and please be aware that we use the same method. Regarding kidney transplants, there are reports that it suppresses rejection reactions, protects kidney function, reduces cardiovascular complications, and has antiviral effect against cytomegalovirus and BK virus. However, it's known to cause urinary protein, stomatitis, and dyslipidemia. Left two graphs indicate the cumulative incidence of cytomegalovirus DNAmia and cytomegalovirus DNAmia followed antiviral treatment. Comparing to the MPA group, iberolims group could suppress the rate of cytomegalo infection. On the right two graphs indicate compared with MPA, iberolims suppress the incidence of not only cytomegalovirus DNAmia, but also cytomegalovirus disease. But the suppression of both morbidities disappeared when iberolims was discontinued. Furthermore, the treatment failure rate at week 8 in the case of cytomegalovirus disease infection was also shown to be significantly better in the iberolims group than in the MPA group. Interestingly, recent studies have examined iberolims' effect on COVID-19 vaccination response in transplant recipient, particularly in elder patients. Findings indicate iberolims may influence antibody acquisition rate after vaccination. This data is important for current clinical practice as it helps us understand how to balance immunosuppression with effective vaccination strategies for transplant recipients. This slide shows the SIR of de novo cancer types caused by viral infection. EV virus, HHV8, HPV, HCV, and HPV are well known and show high SIRs. From this perspective, iberolims, which suppress viral infection, is also suggested to have a potential to suppress calciogenesis. For real-world data, I'd like to share our protocol for immunosuppressant and the result of patient survival rate or graft survival rate. We divide it into 4 groups. Group 1 is before 1982. Group 2 is from 1983 to 2000. Group 3 is from 2001 to 2011. Group 4 is mainly after 2012. The patient categorized into the following group based on the type of induction immunosuppressive therapy. Group 1, patient who received antiproliferative agent, azathioprine or mesalazine, and prednisolone. Group 2, patient who received CNI, it's cyclosporin A or tacrolimus, antiproliferative agent, azathioprine or mesalazine, and prednisolone. Group 3, patient who received CNIs, MMF, and prednisolone. And Group 4, patient who received CNIs, MMF, mTOR inhibitor, and prednisolone. This group targeted patients who started taking mTOR inhibitor immediately after the kidney transplantation and continued for more than a year. Moreover, 21 patients who received CNI, mTOR inhibitor, and prednisolone for induction immunosuppressive therapy were included into Group 4. The target trough level of CNI at 1 year after kidney transplantation were from 80 to 100 nanogram per milliliter with cyclosporine A, and from 4 to 6 nanogram per milliliter tacrolimus. Depending on the patient age and primary disease, steroid was discontinued 3 weeks after kidney transplantation. The median follow-up durations were 21.6, 18.8, 10.7, and 4.9 years in groups 1, 2, 3, and 4, respectively. Although 24 recipients started mTOR inhibitors as prescribed, they couldn't take it for more than a year and were included in Group 3. The reasons for discontinuing oral administration were stomatitis, followed by proteinuria, leg edema, and diarrhea. The number of elderly patients was particularly high in Group 3 and Group 4. Moreover, the number of transplantations from ABO incompatible or unrelated donors and the number of preemptive kidney transplantation were statistically significantly higher in recent years. In the overall cohort, 242 patients were diagnosed with de novo cancers, including 30 patients who developed 2 primary cancers and 3 patients who developed 3 primary cancers after kidney transplantation. The mean intervals between kidney transplantation and cancer diagnosis were 21.9, 14.5, and 6.9 years in Group 1, 2, and 3, respectively. In Group 4, there was only 1 patient who suffered de novo cancer, and the interval was 1.2 years. The patient whose cancer in Group 4 was diagnosed at 47 years of age. Previously received kidney transplantation in 2013 and received multi-drug immunosuppressive therapy with tacrolimus, MMF, and prednisolone for 6 years after the first kidney transplantation. The mean period from transplantation to cancer diagnosis and the age of cancer diagnosis were significantly different among the 4 groups. The cumulative incidence rate for each group are shown. The left shows all de novo cancers, and the right shows de novo cancers without non-melanoma skin cancers. As time has passed, the immunosuppressive effect has gradually become stronger. As a result, the cumulative incidence rate has significantly increased, and the time to onset has also significantly shortened. On the left graph, the 10-year and 15-year cumulative de novo cancer incidence rate was 3.3 and 6.8 in Group 1, 5.6% and 11.8% in Group 2, 11.5% and 19.3% in Group 3, respectively. There were significant differences among the 3 groups. Surprisingly, we used iberolimus for induction therapies significantly suppressed the incidence of de novo cancers. Of course, the observation period was shorter than in other groups. Further long-term follow-up is necessary. But at least this point in time, the superiority of using iberolimus has been suggested. On the other hand, the recipient survival rate and graft survival rate have improved significantly over time. In Group 4, which induces iberolimus, the results have improved even further. Of course, it requires further long-term follow-up. The 5 years overall survival rate after kidney transplantation were 87.2%, 93.6%, 95.6%, and 96.8% in group 1, 2, 3, and 4 respectively, with significant differences among the group except for between groups 3 and 4. The 5 and 10-year death-censored graft survival rate after kidney transplantation were 69.4% and 60.3% in group 1, 84.2% and 73.0% in group 2, and 92.8% and 85.9% in group 3, respectively. The 5-year graft survival rate was 97.5% in group 4, and there are no patients who had been followed up for more than 10 years in this group. The graft survival rate was significantly different among the groups. Because the average observation period in group 4 was short, we performed a multivariate analysis of risk factors for the de novo cancer up to 5 years after kidney transplantation. We found the hazard ratio of transplant history was significantly higher, while the induction of mTOR inhibitor significantly suppressed the de novo cancer. mTOR inhibitor, it means everolimus. Finally, I'd like to talk about adverse events of everolimus. As mentioned earlier, there are the main adverse events and their countermeasures. For side effect, pneumonitis, thrombotic microangiography, surgical scar infection or late healing, lymphocyl, productive surgical drainage, post-transplant diabetes mellitus, hypertriglyceridemia, hypercholesterolemia, proteinuria, and edematous. Established countermeasures have been reported to the most of them. Delayed wound healing and lymphocyl are sometimes pointed out in the perioperative period, but they are not significant in our data. Our data indicate there are no significant difference between the group using only MMF and using MMF and mTOR inhibitor. Stomatitis is a common adverse event, but in most cases, it can be treated with oral care and mucosal protective agent. The photo shows glossitis caused by everolimus, but unfortunately, it didn't improve with oral care alone. When everolimus was discontinued, it improved immediately within 2 weeks. Proteinuria has been noted as an adverse event of everolimus, but at least our experience, we believe the incidence of proteinuria is low when everolimus is used from the time of transplantation for induction therapy. We measured the volume of proteinuria for 2 years after kidney transplantation, but there are no significant difference between the group with everolimus and without everolimus. But we had the impression the incidence of proteinuria is particularly high when we add on everolimus after kidney transplantation. We have divided the patient adding on everolimus after kidney transplantation into 4 groups. It's dividing prophylactically using ARB or not. The volume of urinary protein over 150 or not. When we analyzed our data, we confirmed a daily urinary protein amount of 150 mg per day or more leads to an increasing of proteinuria after starting everolimus, and the increasing of proteinuria can be suppressed by administering an ARB in advance. Anna reported that there is no difference in the survival rate when everolimus was administered within 35 months after kidney transplantation. But the graft survival rate decreased when everolimus was administered to patients with high proteinuria after 35 months. Therefore, in order to use everolimus effectively, it's necessary to start its use as soon as possible after kidney transplantation. And if it's added on after a long period of time, it is necessary to start it after controlling proteinuria to a certain extent. Regarding delayed wound healing and lymphocyte, there are reports that it is related to everolimus and reports that it is not, and opinions are divided. In our facility, we didn't find any difference in the incidence of delayed wound healing and lymphocyte with or without use of everolimus. We use everolimus from the day after kidney transplantation, and we speculate the wound probably heals before the concentration of everolimus increases. Finally, I'd like to introduce the immunosuppression protocol we use at the induction of kidney transplantation. This is our conventional immunosuppression protocol for ABO blood type compatible without preformed DSA cases. The perioperative CNI and target concentration are as shown. We use tacrolimus for 0.15 mg per kilogram per day, and the target trough of tacrolimus is from 7.5 to 10 before day 14 after kidney transplantation. And from day 14 to day 28, the target trough is 7.5. And after 1 month, the target trough is from 5 to 7 nanogram per milliliter. This is the standard protocol we currently use for ABO compatible and without preformed DSA cases. The CNI concentration can be suppressed from the perioperative period, and CNI-related adverse events and infections can be suppressed. For induction therapy, we use tacrolimus, everolimus, and MMF, methylprednisolone, and basilikizumab. And for maintenance therapy, we use 4 drugs: tacrolimus, everolimus, MMF, and prednisolone. We use tacrolimus 0.1 mg per kilogram per day, and the tacrolimus target trough is from 5.0 to 6.0 nanogram per milliliter. For the past 8 years, we have been using a protocol of steroid withdrawal for recipients who are not at risk for recurrent nephritis. We believe this is effective for recipients with primary diseases such as diabetes mellitus or nephrosclerosis and elderly recipients, as it reduces the side effects of steroid. Although we don't have data for today, there was no increase in the risk of developing clinical or biopsy-proven acute rejection. We have already used this protocol for about 150 recipients, but the survival rate and graft survival rate are impressive. It's very good data. Here are take-home messages. Despite the improvement of patient and graft survival rate with the increasing potency of immunosuppressants, the cumulative cancer incidence rate after kidney transplantation increased with a tendency for shorter time from kidney transplantation to cancer development. The addition of mTOR inhibitors, everolimus, to conventional induction immunosuppressive therapy was not only associated with improved patient and graft survival rate, but also with reduced cancer incidence, at least in the short term after kidney transplantation. Thank you for your attention.